Thanks very much, Paul. Thanks for the very kind introduction. It's lovely to be here back in Qatar for the second time. And when I was asked to give this talk, I tried to get an idea who the audience would be. And obviously, I understand it's quite a diverse group. So I tried to pick a topic that you may not hear a lot about, but that would still be of interest, and tried to pitch it at a level that will be at least interesting to the majority of people, I hope. These are my disclosures. So firstly, thanks for the invitation. As I said, it's the second time I've been here, and it's great to see how much progress has happened in the last 12 months as we look at things from a scientific advisory board point of view. It's obviously going a long way, and a lot of good recruitments recently. It's great to catch up with my good friend Peter, and my very good friend Al Getgood has just joined, so another bonus reason for me to come over to Qatar. And a real privilege to meet Tim Cahill, who's a legend in our country and obviously doing some pretty amazing things for Qatar football as well. Just a little bit about me. So I'm a knee surgeon, as Paul said. I do just knee surgery. I work in, I do about 300 knee replacements a year, about 200 ACLs a year, and about 40 osteotomies a year, and other stuff as well. But just knee surgery. And I work in private practice and also work in academic practice. This is the teaching hospital I work at Royal North Shore, which is about 5 minutes drive north of the Sydney Harbour Bridge. I live in Sydney, Australia, which is just down there for those who don't know. And if you don't know, it's 16 hours flight. So if you ever want to go there, it's pretty easy. Just hop on the plane. It's only one flight and go for a sleep, watch a few movies, and you're there. It's a pretty good place to visit. For those who haven't been there, please come down and visit us. And we started our own private research institute. This is where most of our research is done, and it's a similar facility to what you have here in terms of the work you do. We do a lot of stuff around return to sport for ACL, but obviously on a slightly smaller scale. But we started this more than 20 years ago, and now we've got over 20,000 patients in our database. So this is what feeds the research that we do. So I talked today about osteotomy, and I've sort of entitled this "Working Towards the Perfect Correction," because a lot of our research is really just trying to refine this osteotomy and work out who the best patients are, and how to get the best possible result in those patients. So in this talk, I want to talk initially just about the general principles of osteotomy, talk about who it's appropriate for, how we plan and prepare for an osteotomy, how we do an osteotomy, and then I'm going to share a little bit of the more recent research that we're doing, working towards these goals and trying to refine this process further. And during the talk, I'll have a few examples just to illustrate what we're doing. So the general principles of osteotomy, it's an operation that's really based on intuition. And it's a pretty simple concept. If you have someone, this is Olympic mogul skier, and she turned up. You can see she's had 2 ACL reconstructions, and she's in varus on both sides. And she's got bad medial compartment arthritis in the left, and that's right where her body weight goes through. So if we do an operation to shift the body weight to the other side of the knee, it's probably going to hurt less. So it's a pretty simple concept to try and relieve people's pain. And this was first described many years ago. So it's a very traditional operation. And the outcomes of osteotomy are generally pretty good in well-selected patients. If you do the surgery well, again, the same patient, same operation, and 6 months later, she can hike up the mountains and she can ski. Now, this is obviously a very motivated patient, so all the results don't look like this, but these are ones that can demonstrate, even with a really bad knee, in a young patient, you don't have to do a knee replacement, because this operation reduces pain, it improves function, and it preserves the knee joint, and doesn't really compromise anything for the future management. It's always been a poorer cousin to joint replacement, particularly since joint replacement became much more refined and much more successful. And of course, it does have narrower indications. We don't tend to do it on more severe arthritis or if someone's really stiff. But in addition to that, there's less research and development around it. There's less investment. Companies make a lot more money out of doing a knee replacement than selling an osteotomy plate and screws, and therefore there's less science dedicated to it. So I think for those of us who are interested, if we can study it a bit more, we can probably optimize and get better utilization out of this procedure. And a lot of my inspiration came from one of my mentors, Pete Fowler, also a mentor of Al's, and Pete was really big on alignment and the value of doing this and preserving the joint, and he used to refer to joint replacements as fake knees. So how can we improve osteotomy? I think there are things we can do around improving the selection of the patients. We can do better preoperative assessment and planning. We can do the surgery better. There may be things such as you're working here with your biologics labs that can help supplement these operations to help regenerate tissue better. We can make the post-operative management better. And all of this will improve outcomes and increase the utilization. Because I think in a lot of places, particularly in the US, people just don't do osteotomy because they're not comfortable doing it. They don't really know how to do it. And therefore, everybody tends to veer toward knee replacement. And therefore, you have people in their 30s and 40s having a knee replacement when they could probably have an operation that preserves their own knee. So who should have an osteotomy? Well, the indications, we generally will do it most commonly for arthritis in a younger and more active patient, but there are a lot more indications. If someone has a deficiency of the meniscus and they're symptomatic and they're malaligned, or they've got chondral pathology. So this patient here was having a chondral procedure. Their alignment was not favorable, so we did the chondral procedure and changed their alignment. Instability is a big thing now for osteotomies. So instability in the coronal plane where they've got a lateral sided deficiency. If you just try and do a soft tissue reconstruction in the face of significant malalignment, it will fail. So you need to correct the alignment and do the soft tissue reconstruction. And then more unusual cases such as deformity correction. And we're talking mostly about a coronal plane correction, but it can be in the sagittal plane, it can be in the rotational plane as well. So for example, this recurvatum deformity can be corrected and get rid of the recurvatum instability. So there's a lot of indications for doing an osteotomy beyond just osteoarthritis, but the most common indication is arthritis in the younger patient. And if we look at what are the predictors of outcome, this literature would suggest that we get better long-term outcomes if we do it on people with a lower age, they have a lower BMI, they have a good range of motion, their arthritis isn't so bad, they've got a well-preserved lateral compartment. So all of these things are tending towards arguing for earlier intervention if you want to get a better outcome and a longer-term outcome. So our own database, we've got 550 patients in total in the database. Close to 500 of those are just the opening wedge osteotomy, so a reasonable number that we can study all of these things on. And when we look at our results, so across all the PROMs, we get significant improvements. So we can look at this and say to our patients, yes, this is the results that you're going to get. However, if we compare the PROMs to normal PROMs in people who don't have any arthritis, normal knees, they're not as good. So the message to patients is we can make you significantly better, improve your pain, improve your activity, but we're not necessarily going to make you normal. And I think that's an important message to get across to people to get the right expectations. When we look at their PROMs over time, for the ones who haven't had to have any further surgery, then those PROMs, their outcomes tend to be sustained over a longer period of time, except the one sports score, which obviously naturally tends to decline a bit with age. So there's sustained results as well. Now we can also look at how many of these patients end up having a knee replacement. We can look at our own database, we can look at the Australian Joint Registry. And over this group of patients, about 500 of them, at about 5 years, there's 2% that went on to knee replacement. That's probably poorly selected patients. At 10 years, it's about 18%, and 15 years, 37%. Now, we obviously think if we do the surgery better from learning from this experience, we can probably make these numbers better. So I usually tell people that there's about a 90% chance they can get to 10 years, and there's about a 80% chance or 75% chance they can go to 15 years. But when I'm doing those sort of calculations, I should also be putting in to our algorithm, which we can do now, is their age, their activity level, their degree of arthritis, and it can spit out a much more accurate prediction. So the things that affect the survival, so these are survival curves. So the lower it is on the curve, the worse the survival. So this is looking at the cartilage on the medial compartment of the knee, on their medial femoral side. So the green is where they got bare bone, and the blue is where they still have some cartilage left. So if they have bare bone, if they got worse arthritis on the medial side, they still get a good result, but it doesn't last quite as long. Patellofemoral disease, so arthritis, we often wonder about this. We wonder, will this compromise the outcome? Well, in our experience, it doesn't seem to. They still get just as good a survival. So the only caveat on that would be that if someone comes and they've got patellofemoral disease and bad patellofemoral symptoms, then you'd probably be more reluctant. But if all their symptoms are medial, you can generally ignore the disease you see in the patellofemoral compartment. BMI didn't seem to have any effect, but age did. So the older the patient, the more likely they were to have a knee replacement earlier, which may be also a reflection of surgeons' tendency to operate earlier on people as they're getting older and hold off on younger people as well. This is looking at the surgical aspects. So the MPTA is the angle of the tibial joint line when you're looking at it from the front. Okay, now we change that when we do an osteotomy. And we know, and it's been well described, if you go a bit too far, create a bit too much deformity, it might affect the outcome. So when we set the cutoff at about 5 degrees of valgus on that proximal tibia, we tend to see worse outcomes. So that gives an indication as to how far we're comfortable to go with our correction. And the same with what we call the joint line obliquity. Now this is when you look at a knee and an x-ray and the line of that joint line in relation to the line parallel to the floor. So most people are tipped into a little bit of varus. If we tip them the other way too much, we've shown that that can affect their outcome and the survival. So again, these are things that go into planning our procedure, as I'll show you a bit later on. If we look at people who had knee replacements versus those who didn't have knee replacements, then generally speaking, the ones who have had knee replacements have worse arthritis, they need a bigger correction, and their preoperative scores are worse. So you're generally talking about patients who are already further down the road of arthritis. So that's probably not surprising that they don't tend to last as long before they need a knee replacement. So just concluding, the things that seem to affect the survival outcome, we know that we can get good clinical outcomes on patients who are appropriate. We get improved survival if they've got less cartilage wear, if they're younger patients with smaller corrections, and particularly if we get a more precise correction and avoiding overcorrection. So I think what we'll have in the future is we'll have an algorithm and we'll put all the factors for different patients in. It'll be their age, their gender, their alignment, the degree of their arthritis, and we'll get an indication as to what the best prescription for the correction is, but also it will give us a much better prediction of how long it will last them, and then they can decide whether it's really worth going ahead with an osteotomy or whether they should have a knee replacement. So that's a better way to have data and evidence-based made decisions about what we do to our patients. So moving on about how we plan and prepare for an osteotomy. So how do we measure alignment? So this is how we measure alignments. I'm not sure if you have EOS scans here, but they're a low-dose radiation, weight-bearing, AP, and lateral x-rays. So we can get a full-length AP, we can get a full-length lateral, we get the overall alignment in the two planes, we get all the joint line angles. So the distal femoral angle, the proximal tibial angle, and the tibial slope, all the things that we use for our planning. Of course, there's some limitations with radiology planning in terms of the fact that they're static images. They can be susceptible to rotational flexion contractures, but our engineers that do all this planning can now manipulate those images to try and correct for a lot of those things. We also use gait analysis, so again, to try and get to the more dynamic side of things. And obviously this is not something that everybody can do. It's quite labor intensive and costly, but we try and do this preoperatively and postoperatively on all of our osteotomy patients. And that helps us define and refine what we're doing for osteotomies, as I'll show you a bit later. So we measure these curves, measuring the force across the medial side of the knee, and we can show how much it reduces from the red to the black line. We can get these nice diagrams looking at the ground reaction force on a patient pre and post osteotomy. And if you want to do additional research, then we can model things like the forces on the articular cartilage and see how those are affected. So again, this is mostly a research tool to help us refine better how we're doing this operation. But we do use this interacting with patients. So this is the data that we get after a high tibial osteotomy, and you'll see the red line. So the knee adductor moment is what we're talking about, which is a measure that correlates to the load on the medial compartment. So you can see how it goes from the red down to the black line. And when we see a patient post-operative, I can show them these graphs and show them how this has helped, what we've done mechanically and how it correlates to their symptoms. It's quite good feedback for them. If we change people in the other direction, from valgus to varus, you'll see that curve goes up in the other direction, obviously. So now the big question around this is obviously what alignment should we aim for? And yeah, in the previous times, it's obviously people tend to look at it with their thumb. We had an old surgeon in Australia who lives down in Tasmania, which is down the bottom of Australia, sort of a remote area. And when someone asked him, his answer was, well, you always change it by about 1 centimetre. And in some people, it's a big centimetre, and other people, it's a small centimetre. So we're sort of trying to get a little bit beyond that in terms of how we refine this, and there really isn't a consensus in exactly what we should be aiming for. People are getting closer and agreeing more, but the way that they measure this and the outcomes they use to determine this could be the survival, it could be PROMs, it could be cartilage wear, it could be gait analysis. What we try and do is look at all of these things and work out what's the best alignment to achieve the best results in all of those things. And traditionally, back in those days of Coventry, where I showed you several decades ago, it was aiming for a big correction. So people would be going to quite a lot of valgus. And we know now we don't need to do it that much. And so we've come back a little bit more to, rather than 5 degrees of valgus, to maybe 2.5 degrees of valgus, but we're still refining it. So this is a finite element analysis study where we did a simulated osteotomy and looked at the loads changing from the medial to the lateral compartment as we went from varus to valgus. And what we found is that at about 1.5 degrees of valgus, the loads are pretty equal, which sort of makes sense because your center of gravity is medial to the knee. So when you're single weight bearing, you will be loading the medial side more if you're neutral. So there is the rationale for having a bit of an overcorrection, particularly if you're trying to offload the medial compartment. We've done gait studies, and when we do look at all of our patients and we've corrected them to about 2 or 3 degrees using navigation, we tend to obliterate the adductor moment, so that shows the mechanical effect we're trying to achieve. And we've also done cartilage studies looking at cartilage recovery after 2 years, and we see this recovery. So that alignment strategy seems to create a good enough environment for some cartilage regeneration. So that seems to be a reasonable ballpark figure, but as I'll show you later, we're trying to refine that a little bit better. So should we do our correction on the femur or the tibia? Well, we need to look exactly where the site of the deformity is, and when we do our planning, we'll get all those measurements. We need to look at the degree of the correction and the orientation of the joint line. But typically, most commonly, we'll do an osteotomy on the tibia for a varus deformity. We'll do it on the femur for a valgus deformity. But occasionally, and depending on where the size of the correction and where the deformity is, we may do a correction on the tibial side for valgus. And sometimes if we have a bigger deformity, as I'll show you in a minute, then we have to do 2 osteotomies because we're going to distort the joint line too much. So in general, when we're trying to work out what alignment we do, we have an individualized prescription depending on the patient's pathology. But in general, if they've got established arthritis, we're aiming for about 2 or 3 degrees of valgus. If they've got early arthritis, then maybe we just need to equalize the forces, more like 1 to 2 degrees of valgus. If it's instability and we're going to do a soft tissue reconstruction, neutral alignment is probably enough just to protect those reconstructions. And if it's lateral compartment arthritis, we just correct them to around neutral. But again, we have to do this planning and avoid creating too much of a deformity on that joint line obliquity. So I'll just show you an example, which you saw a little bit of before. So this is a 45-year-old male, and you can see he's got screws in his femurs. He's had a previous multiligament injury. He's had multiple operations. He's 45 years of age. He's fit. He's healthy. He walks in, but he's got pain. He's got a big varus thrust when he walks, and he wants something done about it. And he's got a good range of motion, and he's got a pretty good lateral compartment on his MRI scan. So most of the time, for example, again in the US, this would get a total knee replacement, no doubt. But we wanted to look at a joint preserving procedure. So when we looked at planning a tibial osteotomy, which we mostly do for a varus deformity, you can see it's going to create a pretty huge gap here, and we're going to get 10 degrees of valgus on the tibia. So that to us is unacceptable. That's too much of a deformity. It's not going to have as good an outcome as I showed you before, and it will really compromise a knee replacement in the future, which you'll probably need at some stage in the future. So we changed the plan, and in order to keep the joint line orientation pretty much normal, we thought we'd do an osteotomy on the femur and an osteotomy on the tibia, and so we can individualize the joint line that we're aiming for. And we do a closing wedge on the femur, opening wedge on the tibia, and that way we're not altering his leg length too much either. So we can do really personalize this. We make these PSI guides, as I'll talk about a bit later, to do the surgery, and that makes it a lot easier to do it, and do it simply and do it accurately. And this is what he's like at about 8 weeks post-operatively. So again, pick your patients. It's something that people need to tolerate. But if they're a good patient, then they can usually get through it. And the results are usually sustained over a longer period of time. He's about 4 years out now and still doing well. And this is his gait study. So you can see, I mean, that's a huge change because he had such a huge deformity. Okay? But again, we're demonstrating the mechanical effect. Just another example. So this is a young lady. So she's 31 years of age. She's female. She's got lateral pain. She's had a previous lateral meniscectomy. She really needs a lateral meniscus transplant because her arthritis isn't too bad, but she's got valgus alignment. And you can see if you look at her tibia there that it's actually in some valgus. And it's not a big correction, and we can do the correction on the tibial side, which has benefits over doing on the femoral side. It's a simpler operation, a little bit easier recovery. So for her, we planned a closing wedge osteotomy on the medial side, and we combined that with a lateral meniscus allograft. So again, we're considering all these things, looking where the deformity is and where the best place to do the correction is for the patient. So let's talk quickly about sagittal plane instability. So this is a big topic. It has been for quite a while, but getting a lot more traction lately. So looking at the effect of tibial slope. So for those of you who don't know, if we draw a line up the tibia and a line usually down the medial tibial plateau, it creates a downslope in most patients. It's quite variable between patients, quite variable between races. And it's something that has an impact on the mechanics of the knee, and something that we look at very carefully in osteotomy and in ACL reconstruction. And if you think of it very simply, when you have that picture on the right there and you have a downslope, the femur wants to slide down that slope. So relatively speaking, the tibia comes forward. That's not so good for an ACL. It helps a PCL. Okay. If you have the alternate situation where you've got a flatter slope, that's helpful for the ACL because the femur will slide forward, but it's not so good for the PCL. And this is stuff that when I worked back in Fowler Kennedy a long time ago, a lot of research was done on that, showing that the more you increase the slope, the more you get this anterior translation effect. And a lot of people looked this over the years and showed a very clear association between a high tibial slope and failure of ACL grafts. So it's something that we should all be looking at very closely when we're doing ACL surgery, and particularly when we're analysing why ACL surgery might fail. This is a pretty staggering study out of the US. They looked at revision ACLs, and in terms of the failure rate, it was increased by a factor of 18 if the slope was more than 14 degrees. Okay, so it's obviously something we need to look at very closely. And we don't look at this as much, but the opposite effect happens with PCL injuries. So there's been shown that if you have a flatter slope, it's not favorable for PCL and can lead to worse outcomes with PCL reconstruction. So again, having an appreciation of this alignment in the other plane is really important, in the sagittal plane. So the indications for changing someone's tibial slope, you want to increase the slope, most commonly in a PCL injury. Okay, occasionally if someone, as I'll show you later, has recurvatum, maybe from a previous injury, and they have recurvatum instability. And you want to decrease the slope if someone's had ACL instability. We don't tend to do it for primary ACL injuries. That's a big discussion point, but particularly in revision ACL reconstructions, we like to look at that very closely, and there's a lot of techniques for doing that. So just to show you some examples of that, so this is one of my colleagues works in the kids hospital, and this is a patient who had a growth arrest from an injury at a young age. You can see that tibial slope on the right there. It's a reverse tibial slope, and you can see how the femur slides forward and the patient will go into hyperextension. So we want to correct that. So we can take a model of the other knee to see what their normal slope is and use that to base our planning on. And so you can see the correction that we plan here. So when we do the surgery, we can make a 3D printed guide, firstly to take off the tibial tubercle and drill the holes for the plate. The next guide guides the osteotomy to open up at the front to reduce the slope, so to increase the slope. We can do another guide that cuts out a wedge of allograft bone to fill in that gap, and then that's the end result. So it makes a very complex deformity very simple to plan and to execute. Another example, this is a failed ACL reconstruction. So a 28-year-old second grade rugby player had a surgery back in England a couple of years earlier, had a hamstring graft, had a fairly uneventful recovery, but he had a re-injury not long after getting back to playing sports. It was a non-contact injury, and he had an unstable knee again. And those of you who do ACL reconstructions will look at that and think, well, the tunnel position's probably not perfect, and I'll show you how we analyze that. He's got some medium meniscal pathology, and his alignment is in varus. So when we do revision ACL planning, we look not just at the tunnels, we look at the tunnels here. So when we do the planning, the red is the old tunnel, and the green is where we want to put the new tunnel. Okay, so that's a difficult situation to deal with, because you have a very big old tunnel and you want to drill a new tunnel, end up with a very big tunnel. So that's a situation where many people would say, okay, we'll bone graft that and we'll come back and do the revision later on. If we look at it on the tibial side, then again here, this one isn't so bad, so that's probably something you could deal with easier in a single stage. But then the other thing, as I said, we look at is the coronal plane alignment and the sagittal plane alignment. So this person's in 4 degrees of varus, he's got some medial meniscal deficiency, he's got some chondral wear, so that probably needs to be corrected, and he's got a very big slope of 20 degrees. So most of us would agree if you just did a revision ACL reconstruction in that scenario, no matter how well you do it, it's going to have a very high chance of failure. So the plan with this patient was to do the corrective osteotomy, to correct their varus, correct their slope, bone graft the previous tunnels, and then come back and do a revision ACL reconstruction later. So you can see the guides are made here, and this one is a little bit asymmetric. So it's an anterolateral closing wedge to create some valgus and also reduce the slope. So again, this can be planned very precisely, and this is what the end result is. And so that patient will get followed, they'll rehabilitate. It may be that because we've reduced their slope so much that their knee doesn't actually feel so stable. But there'll be the option of coming back and doing a revision reconstruction later on. It will be a simpler operation and it'll be a much higher chance of success. So again, if we just looked at that patient previously and said, well, their tunnel position was no good previously, let's just do another reconstruction, it will probably fail. So I think that's really important that we have that very detailed sort of multi-plane analysis. So in terms of how we do the surgery, this is how we do it traditionally. So we do preoperative calculations, we measure angles, we translate those angles onto a bone. During the operation we get a line like the diathermy cord, or we get a rod and we just sort of look at it and we say that looks pretty good. And a lot of the time if you do your preoperative calculations well, that can actually be pretty accurate. But we can take a step further than that. And about almost 20 years ago now, I started using computer navigation for knee replacements, and I figured it was a pretty sensible thing to use for osteotomy, being an alignment-based procedure. So we've been using it a long time for navigation. It's been shown to improve accuracy. We felt that would improve the outcome. We can look at someone's alignment as we move their knee up and down more dynamically, and we can look at the coronal sagittal plane. So this is something that I was enthusiastic, and I mean, still I've changed from navigation to robotics for knee replacement. And if you look at the literature, there's not as much literature for this as there is around knee replacement surgery, but there's relatively positive literature for just improving and making more reproducible the alignment that we're aiming for. And when we started doing it, we looked at our results and found that it looked correlated well to the post-operative x-ray. So we're pretty happy that navigation was a very accurate way to do this. That's been my standard practice for about 15 years. We published a few studies on this showing it's good. But more recently, as you saw in some of those earlier slides, we transitioned to these 3D printed custom guides, and I'll explain why. So it's an image-based modality, 3D printed patient-specific guides. It's been well established in arthroplasty, and in fact, when it first came out in arthroplasty 10 more years ago, we looked at it, we analysed it, published some papers, and showed it actually wasn't very accurate. So I think the first iterations of this were not particularly accurate, but with time it's become more refined and a lot more accurate. What we felt is that, as you saw in some of those previous examples, it allows us to do a bit better virtual planning in 3D and probably improved efficiency with good accuracy, so we don't have the need to put all these trackers in. So the way the process works is we get our preoperative x-ray, the EOS x-ray, and we can look at the alignment in the two planes. And then all that alignment will go into an app, and then the surgeon can look at the app and they can adjust the alignment in the coronal plane to where they want it to be and what they think is going to be the ideal alignment. And then if they want to, they can change it in the sagittal plane and change the tibial slope as well. And then that gets translated to the patient's specific anatomy, trying to look at how we're going to correct that to that alignment. The CT scan is used to create the three-dimensional model, and then we get a 3D printed guide. And this is how it looks like in the operating room. You can see here on this one, there's a 3D printed guide in place, but there's also navigation trackers. So when we first started doing this, for about the first 50 or 60 cases, we did them with navigation as well, just to double check that it was actually pretty accurate. And this is what it looks like. So when you put the guide on, you put your pins in, you check that against the plan that you already have printed out beforehand to make sure it's in exactly the right place before you proceed. And you have all these double checks here. So the plan will tell you how big the gap needs to be at the front of the tibia and at the back of the tibia. And that's the finished product. And when we looked at the first 55 cases, we found a very good correlation with the navigation and what the PSI was trying to achieve. So we became very comfortable with using this system, and other people have published on this as well. So I just wanted to share a little, just for the last bit, just some of the research that we're doing. So this gets a little bit basic sciencey, so I hope it's still of interest to you. But really what we're trying to achieve here is just to use the research and the database that we have to continue to refine this prescription, how we choose patients, how we pick the alignment for them, how we execute that. And a lot of this work right now has been done by Taka here, who's a fellow from Japan, who's come do some research with me. And prior to that, he spent a year with Al, so he's getting a full heavy load of osteotomy. So I'll just share with you some of the work that he's been doing, some of which is a bit of a work in progress. So initially he looked at the accuracy of the PSI guides and found that this was the error. So a good error, very low error and a very low standard deviation, and the PROMs were all significant improvements. But when you look at averages, there might be people a long way away from the average. So we looked in this a little bit deeper, didn't want to just accept this. So we looked specifically at the type of errors that we might have when we're doing our planning. Now we think we've got down to a very low point the radiographic error, because we align them better, our radiographic techniques are better. So really we're talking about surgeon error versus planning error, which probably gives overall error. So we looked at about 58 cases who had open edge osteotomies with the PSI guide, and we compared the planning guidelines to what we saw at 6 months post-op. So all these patients get a 6-month gait analysis and a 6-month long leg x-ray EOS. And we looked at the overall error in detail, so the surgical error and the planning error, and we compared pre-op variables between the optimal ones, the ones that were perfect, and the ones that were a little bit suboptimal, to try and work out how we can make this planning process a bit better. So when you looked at this, the overall error was still 0.1 degree, so very small. The MPTA, which is how we as surgeons change the angle on the tibia, that was 0.7. So we had a planning error in the other direction that evened things out a bit. So if you look into things more closely, then you find the error is possibly a little bit worse than you thought. Still not bad, but there's still room for improvement. And then he tried to work out, what does this correlate to? Does it correlate to the patient's alignment? Does it correlate to the joint line angle? And really what he found was that it correlated just to the joint line congruency angle. Now I'm going to explain that for you, because that's the thing we talk about a lot, but if you haven't heard it before, you won't know. If you see the two white lines that I've drawn there, one is along the tibia and one is along the femur. And they're not parallel when someone's standing up. Sometimes they are, but sometimes they're not. And what this means is that it tends to be closing down on this side or opening up on this side, or a bit of both. And what we've been traditionally told is that when someone's standing, that's the laxity in the joint, and we need to subtract that angle from our correction when we're planning an osteotomy. That's the traditional thing. What we found is that when we subtract that whole angle, we tend to undercorrect people. So we thought we'd better refine this. And nobody's really looked at this. It's just folklore. It gets passed down like a lot of things in orthopedics. So what we found is there was a very strong correlation between the preoperative joint line congruency angle and the planning error. We found that it didn't really have much of an effect up to about 2.8 degrees. That's one useful clinical thing, that if it's less than 3 degrees, you can probably ignore it and just carry on with your planning as you were going to do. What we found a really strong correlation with was the change in that joint line congruency angle. So we look at it pre and we look at it post-operative, look at the difference, and that correlated very well to the error in the planning. The tricky thing is we don't know what it's going to be after the surgery until we've done the surgery. But we did some simulations where we used the preoperative non-weight bearing x-ray to look at that angle and subtracted that from the weight bearing x-ray. And really what we found, if we'd used that to correct the planning, it became a lot more accurate. So here's an example. This person is having an osteotomy and they had very good precision. They had very accurate, and they had really no change in pre and post-op in the joint line congruency angle. So that sort of fits that system and that planning process. This person had a degree difference, they had a degree error. So in this person, if we changed the planning the way we suggested, we would have not corrected them as much. Okay, so it's a way that we're trying to refine it in the way that other people haven't really done before, to try and get a much better idea as to how we deal with that opening that we see in a weight-bearing x-ray. So based on what he found, we've shown that the system is very accurate. We found that the increased JLCA was a risk factor for suboptimal planning, particularly if it's above 3 degrees. And the method where we adjust it just that little bit based on the weight-bearing x-ray and the non-weight-bearing x-ray will improve the precision of what we do. As I mentioned before, we do gait analysis on all of our patients preoperatively and 6 months post-operatively. I think we've got a system, there's a Vicon system very similar to what you have here. And we collect a lot of things, a lot of kinetics, a lot of kinematics, but what we're focusing on here is the knee adductor moment, which is a surrogate of the force going across the medial side of the knee, which is what we're trying to change when we do an osteotomy. So we're using this to try and, again, rather than just rely on an x-ray, static x-ray, look at this force and how does this relate to the outcome? How can we use this to plan the osteotomy better? So we had 22 cases that had this done pre and post-operatively. We compared their gait data, their adductor moment pre and post-operatively, and compared the radiographic variables. And when we look at the radiographic variables, obviously when we change the knee, it might affect the hip, it might affect the ankle. Okay, so we look at all those things too and look for correlations there. So as you expect, as I showed before, when we do an osteotomy, we reduce that adductor moment from the blue line down to the red line. As you expect, significant changes in that. If we look at the radiographic variables, then at the knee level, we change from a neutral joint line to a more valgus joint line. The ankle changes from a varus to a valgus orientation, and the hip changes as well. So when we do an osteotomy, we have impacts on the adjacent joints. If we try and look at the correlation between the peak adductor moment, that force, and the outcomes, not surprisingly, preoperatively, the worse the deformity, the worse the adductor moment, the worse their proms. Okay, so the bigger deformity, the worse the scores are before the surgery. And what we found after the surgery is that we saw the people who had the higher KAM actually had better results. Now that's a little bit counterintuitive because you're trying to reduce it, but remember here we're looking at the corrected range. So some of those will be down the lower end of the correction, some will be the higher. So the ones who are down the lower end seem to get better results. So what we're trying to define here is how far we correct people to get the best possible results. And we can look at the numbers that we need with these figures to get the minimal important difference and the substantive difference. So again, this is getting a little bit technical, but what we've found here is that we can use these numbers to define what we think is actually the ideal correction that's going to get the best outcomes for different patients. And very simply, what we've found is that we talked about aiming for 2 to 3 degrees before. People who are more towards the 2 degrees got better results. If you go a little bit beyond 3 degrees, then the results tend to decline. So we're bringing that correction down lower and validating that in terms of getting better proms and hopefully getting better long-term survival. So how does this work? What's the clinical relevance? So I think Gait lab studies, they're time-consuming, they're arduous, but they can help refine the ideal correction. I think looking at these adductor moments might help predict the post-operative proms, and overcorrection tends to get worse outcomes. And we can define these ranges for those of us who use the Gait lab, and we can hopefully then translate that to how we recommend what people plan. If you look at the variables in terms of the KAM change and the radiographic variables, actually what we found is there was a significant correlation with what we saw in the ankle joint line. So the change in the ankle joint line obliquity. So we saw a correlation with the knee alignment, not surprisingly, the weight-bearing line, but also the ankle joint line. Post-operatively, we didn't find any real correlation with the variables, probably because everything's pretty closely kept together. There's not a huge variation. But we did find a significant correlation between the change in those forces and the ankle joint line. So we do get change in the ankle joint line when we do an osteotomy. So it's something to think about when we're looking at this, and something we need to consider. And certainly when we're assessing people for osteotomy, we need to think about their ankle joint line, particularly if their ankle has arthritis or it's stiff. You need to know that before you plan an osteotomy because it may compromise their outcome. So I'm going to finish with one sort of funky sort of case. This is a woman who's like 40 years of age, and she's from Thailand. She came to my public hospital clinic with this leg looking like this, and she's a hairdresser. She stands up all day. She's actually pretty tolerant, but you can see she's got this huge deformity and this basically sublux joint here. And if you look here, you can see she's got valgus in the femur, which was somebody's previous attempt to try and correct the varus deformity by changing the femur into valgus. You can see that didn't work. Okay, it didn't really work on the principles of corrected the deformity. So a lot of people would say, okay, she just needs a knee replacement. It's a very difficult knee replacement, and she's 42 years of age, so it's probably not the best outcome. So we figured we'd probably just try and restore anatomy as close as possible. So we did a femoral osteotomy to undo what was done before by a closing wedge, and the tibia needed a huge correction in the sagittal plane and the coronal plane, which we planned out, and we had cutting guides made for that. And obviously it's very hard to deal with this anatomy. And then post-operatively, that's what her alignment looked like. Clinically, that's what her x-ray looked like. So you can see at least the femur sitting on the tibia. She's actually done very well clinically. The osteotomies did heal, and I think she has a better template in the future for a knee replacement. So in conclusion, it's a good operation. I mean, the clinical outcomes are good in the right patient. Survival is affected by several factors, and I think we get better survival, better outcomes if we have better patient selection, if we do the surgery better. Maybe the addition of biologics, maybe the new biologics lab you've got here will help improve the results for Al's osteotomies. I'd really like to see. We've done some work on that, but didn't have enough time to present that today. But I think in the future, as I said before, these decisions need to be informed by evidence. So we'll hopefully have an algorithm in the future that takes into all these factors into account. And at the other end, it spits out what's the appropriate operation, what's the appropriate prescription, and then you have a very precise way to do them and get good outcomes for the patients. So thank you for your attention. I hope that was of some interest to you all, and I really look forward to seeing all of you in Munich